Good morning. I'd like to welcome you to the Urgo Medical Symposium entitled Put Your Patients with Diabetes Back on Their Feet Sooner, DFU Management from Clinical Evidence to Real-Life Efficiency. I like to introduce myself shortly. I am Ralf Lobmann. I am the head of the Department of Endocrinology, Diabetics and Geriatry in Stuttgart. We have special times, extraordinary times, and therefore we have a digital meeting. And I like to introduce all our speakers and topics. First of all, Dr. Raju Ahluwalia. He's an executive member of the Diabetic Foot Study Group of the ESD. He is a consultant orthopedic surgeon specialized in foot and ankle disorders of the King's College in London. And he will talk to us about the current and rising key challenges in DFU management. His presentation is followed by Professor Marco Meloni. He is a research fellow at the Diabetic Foot Unit at the University of Rome. He's operating in the prevention and the treatment of diabetic foot, including surgical and medical approach since 2007. He's a board member of the International Diabetic Foot Care Group and the Italian Diabetic Foot Study Group. And he was also involved in the fast-track pathway and guidelines during the COVID-19 crisis. He will talk about the importance of early and optimized treatment of the diabetic foot ulceration to improve patient outcomes. After the data of the results of the outcome, it's important to talk and to look on the costs of the wound treatment. And Dr. Chris Manu, as a consultant diabetologist at the King's College in London too, will talk to us about this topic, importance of early optimized DFU treatment to generate cost savings. Last but not least, Professor José Luis Làzaro Martinez, Clinical Director and Head of the Diabetic Foot Unit of the Complutense University and the San Carlos Teaching Hospital. He is the Scientific Secretary of the Diabetic Foot Study Group and also the President of the Diabetic Foot International, last but not least, a personal friend of mine. And I'm happy that he will talk to us about the guidelines and present the 1 year after the inclusion of Urgo Start in the International Working Group Guidelines, a retrospective. Next slide, please. As you see, the diabetes is a global emergency. And the epidemiology of the diabetic foot is worldwide increasing. We have 5% of diabetic patients with a history of foot ulceration and a greater than 25% cumulative lifetime incidence. The global diabetic foot ulcer prevalence in an actual paper was 6.3% published by Thang and colleagues. And the prevalence in Europe is around about 5.5%. The highest prevalence is found in North America with 13%. The patients with diabetic foot ulcers were older, has a lower body mass index, a longer diabetes duration, had more complications like hypertension, diabetic retinopathy, or smoking history than patients without a diabetic ulceration. All these facts suggest for policymakers in deciding preventing strategies of diabetic foot ulcerations in the future. And in a senescent society worldwide, we see an increase of type 2 diabetes, older people and chronic wounds. It's time to act now to stand against the tsunami of non-healing wounds in diabetic patients, because we will not get more financial resource in the future into the healthcare systems, and we have to coordinate the needs to heal the wounds of our patients. Most important is the aspect to avoid the first ulceration. But if we have a wound, we should heal the wound as fast as possible to bring our patients back to their feet sooner. The management of diabetes and diabetes foot ulceration has changed during the COVID-19 pandemic. We saw significant changes in the healthcare system in the clinical practice. A large number of patients were without the need of care. We have seen more amputations and more mortality in the group of patients with diabetes. We need a new triage admission. And for the pathophysiology and inflammatory storm, as we have seen in the COVID-19, we will also find with increases of interleucins, cytokines, or proteases in chronic wounds, in diabetes, or in the Charcot food. During the pandemic, some ulcers became worse or were diagnosed too late because the patients were angry and avoided to come to the food clinics. But on the other side, some patients have had a benefit from the lockdown and a forced state of offloading. So how will or how can we organize social distancing if we have to treat patients and we have to perform a local good wound care? Maybe telemedicine and apps will provide us. We will hear something about this today too. It is surprising. We use digital tools and social media always in our everyday life, but not regularly in the healthcare system. Therefore, COVID-19 will change everything, also in the healthcare system and our SOPs for treating diabetic foot ulcerations. And now we will start with the first presentation. And I'm happy to introduce Raju Ahluwalia with his talk to the current and rising key challenges in the DFU management. Raju, it's yours.
Thank you very much, Professor Lobmann. You've mentioned quite clearly there are rising challenges in diabetic foot, even pre-COVID-19. The tsunami of diabetic foot problems is hitting us worldwide. The costs are going up, but we all are well aware that the cost of treating diabetic foot problems is not going up as fast as the problem itself. Next slide, please. Globally, there are 463 million people with diabetes. The 5-year mortality of a diabetic foot ulcer is greater than cancer. 10 to 15% of these patients will have a diabetic foot ulcer. We worry about major amputation. Major amputation is a risk for death. As we've seen on this slide here, that lung cancer is only greater in terms of a 5-year mortality than a major amputation. In fact, we have made so much progress with breast cancer. It is less than 15% mortality at 5 years, whereas diabetic foot problems in the form of Charcot, diabetic foot ulcer, and major and minor amputation all are close to 25% or above, and in the forms of major amputation with 50% mortality rate. This is concerning because, as we've all seen, as particularly as our colleagues Armstrong, Bolton and Buss have alluded to, recurrence is a problem, not just in treating the primary ulcer, but preventing further ulceration and remission. It is a key element of diabetic foot care that we need to get control of this situation. Next slide, please. 1 in 4 people with diabetes will develop a foot ulcer. That's 25% of the patients with diabetes. One must therefore consider finding stratification tools to identify those patients who have propensity to develop ulcerations. But as we've seen from the previous slide, ulceration itself has a bad prognosis, especially accompanied by amputation, either minor or major. A recent meta-analysis showed that DFUs are accompanied by depression. And even in our own research, we have seen that delayed presentation of a diabetic foot ulcer, the fact that many patients don't understand how severe their ulceration is, we've clearly seen that ulcers in patients who've had diabetes for a shorter time have a greater propensity to believe that their ulceration is more severe, whereas those who have had diabetes for a longer time don't feel their ulcer is such a big problem. This mismatch in understanding of patients is quite important, and it's an important element that we need to address as healthcare professionals to understand how we can treat these patients better, but allow them to be treated early with good intervention, get the patients into remission and keep remission going by good training and education, and something we will come to with our COVID-19 tools and the fast track tool. A foot ulcer left open more than 30 days is more likely to get infected. Well, if patients don't understand the severity of their ulcer or the non-severity of their ulcer, this is going to become a common problem, and it is a common problem. So the identification of the ulcer by HCPs, which are healthcare professionals in society, is important to help the diabetic foot patient. And it's this global understanding around the patient that is key to improve care and get early care to these patients. Next slide, please. Sadly, as we've seen, the mortality after an amputation can be up to 50% in a below knee amputation or a major amputation, whereas minor amputations also carry significant morbidity. And the #1 cause of amputation worldwide now is diabetes. It's not the trauma I see coming into the emergency room. It's neither the vascular disease that is pure vascular disease that my colleagues in vascular surgery say. It is a complication of diabetes, the fact that most diabetic patients are living longer. They develop the risk of amputation. 1 every 20 seconds. That's amazing. In 2020, we still talk about this amputation risk of being 1 every 20 seconds. 70% of these patients who are amputated do not have or will not be alive in 5 years. Again, if we think about it, breast cancer has a better prognosis. And that's quite incredible to think now that in 2020, we have, with good treatment, good preventative measures, and also good ongoing remission treatment for breast cancer, diabetic foot disease is a bigger problem, or the diabetic foot syndrome with an ulceration could be a bigger problem. So there is work to do. And we are all aware that 85% of these amputations could be prevented, which is a sad statistic. It's a statistic that we need to work on. And if you're looking from a value-based agenda, the value in preventing an amputation and all those medical episodes to prevent further ulceration is very important, and it would reduce the cost of diabetic foot care expediently. The lack of awareness and need for patient education remains high. As I've alluded to, lack of prevention can cause ulceration. There is a lack of understanding from our patients, and certainly the studies that IDFCG have conducted over years and audits have shown that perception is sometimes not as one would expect. The understanding of where the foot is at risk, and also leads to delayed referral to specialist care, which is a problem, as we've already seen that 75% of these patients will get an infection if they are left untouched for 30 days. DFUT International and other organizations are leading scientific societies and are able to involved in diabetic foot ulceration care and have identified this need for ulceration. If you look at Mark, there's a video on a Ergo website which shows I never actually realized what was involved in being a diabetic. So education must start from the beginning and go all the way to the end. Next slide, please. I've alluded to this, that there's limited DFU awareness among patients. Therefore, healthcare providers need to be especially careful around diabetes and a diabetic patient, as delayed referral to the specialized setting will lead to further problems. Audits over the last few years have shown that delayed referrals is common between all our nations. I know the UK is leaving Europe soon. However, we share your common problems and we need common pathways and understanding to help our patients. In the acute DFU, it leads to a higher risk of proximal level of amputation, i.e. from a big toe amputation, we're going to disarticulation at the ankle or below knee amputation to salvage limbs that would have been viable if treated earlier on. And frequently major amputation is due to the failed diagnosis of underlying infection and peripheral artery disease, the latter being a significant component in diabetic foot syndrome and condition, as 80% of patients that present at King's have high elements of peripheral arterial disease. Wound healing is significantly affected by delay, and we noted that referral to diabetic foot specialists by GPs after 52 days reduced the healing of that ulcer by greater than 58% in those patients who had been referred earlier. So earlier referral has clinical benefit. Next slide, please. The IDFCG and DFUT International have come together to try and address these problems that we have with diabetic foot education. Low DFU awareness among patients and non-specialists, limited and delayed access, and the identification and decentralization, making people responsible for the diabetic foot ulcer at all levels and improving the follow-up. We've had the fast-track pathway, which in 2019 was published and has been shown by my colleague Marco Meloni, who's talking afterwards, to improve diabetic foot care and possibly get patients earlier to the appropriate person. Now, for 2020, in light of the COVID-19, we have our toolbox for known specialists to allow people to identify diabetic foot disease, but also understand where they can go with the treatment. Diabetic foot ulcers, and with simple instructions for self-care and dressing changes for HCPs and patients who don't normally look after their feet. Finally, the focus in the last few months has been on COVID-19. However, as we've seen, diabetic foot ulcers generalized to have immense economic burden to healthcare providers. In the COVID-19 process, we have seen that patients cannot come to clinics, need to be treated earlier and nearer home. Therefore, we've redrawn the diabetic foot fast-track pathway and have called it version 2. Version 2 builds on the first version, where there is first assessment of comorbidities, the holistic care that is required for all diabetic foot patients. And we've added instrumentation regarding the investigation of COVID-19, which is usually related to local principles or national guidelines. Again, there are 3 types of patients with an uncomplicated DFU, a complicated DFU, or a severely complicated DFU. What has been important for us is to recognize and give the ability of patients and healthcare providers an understanding of a stable DFU, an ulcer that is healing or not healing, but is not impaired in its healing process, to an unstable DFU, which is a foot ulcer that is progressing, most probably because of underlying infection, ischemia, and there is an increase in size, and it is not following the normal healing that one would expect. In these cases, referral is required to the next level of treatment, and this may well be by apps, by telemedicine, and also other variations using media. The management of the stable DFU can remain in the community, whereas an unstable DFU can be pushed up to the next level, whether that is a local treatment provider in diabetic foot care with a specialized MDFT. Further follow-up can be arranged through telemedicine, therefore reducing patients' requirement to come to a clinic and reducing the risk of COVID-19 spread and acquisition. I'm now very proud to introduce my colleague, Dr. Meloni, who will take over the story from now.
Good morning to everybody. Thank you to Go Medical for invitation and for this opportunity to be in this excellent community and for his continued support in the world of wound care. Next slide, please. Focusing on my talk, we know very well that today we have a preset limb salvage protocol for managing patients with diabetic foot ulceration, defined by different but simultaneous steps. So in the case of limb ischemia, we needed to restore foot. In case of infected foot, we needed to manage infection by antibiotic therapy or surgical if required. We needed to offload the affected foot to reduce the trauma and hyperpressure in the wound area, as well as we need to manage a general health status, mainly metabolic control and controlling the cardiovascular risk factor. But to know also that there is a missing step in what that concerns the local wound care. Because even if we know that with the local debridement there is an increasing of wound repair and stimulation of granulation tissue, we have a very few evidence, or we had until few years ago, few evidence about the use of adequate dressing according to the kind of ulceration. And in the majority of cases, the healthcare professional use dressing according to their personal experience or according to the local availability. But we need clinical evidence, we need a dressing that can act against the local factors who impair healing, and that could be easily used in both in hospital and in community setting by expert and not expert clinical professional. Next slide, please. Finally, through the Explore study, we have the first data about the effectiveness of a specific dressing for managing patients with neuroischemic diabetic foot ulceration. Through the use of sucrose octasulfate dressing in addition to a neutral dressing composed by lipido-colloidal technology. The sucrose octasulfate dressing showed great evidence in the treatment of leg ulcer in the past years, both by clinical trials or by data extrapolated by a real-life study. But finally, we had the very robust data, very robust evidence in treating patients with diabetic foot ulceration. Next slide, please. The Explore study was a double-blind, randomized, controlled clinical trial in which 240 patients with neuroischemic diabetic foot ulceration have been included. Patients were divided in two groups. The study group treated by sucrose octasulfate in addition to the neutral dressing composed by lipido-colloidal technology, and the control group treated only by a neutral dressing composed by lipido-colloidal technology. The two groups were treated by the standard of care in the respect of guidance. The study flow was divided in three specific steps. The first one is the run-in period, in which patients were selected according to in the respect of inclusion and exclusion criteria. Patients were treated for 2 weeks with the neutral dressing, and after they were included in the treatment period if they respected the inclusion criteria defined by a wound area regression less than 30%, the absence of infection, the respect of offloading prescription, and in the case of a glycated hemoglobin less than 10%. Patients were randomized divided in two groups, the study group and the control group, and they were treated for 20 weeks until wound healing. Then, after the treatment period, patients were included in the follow-up period in which they were followed for 12 weeks, and in the case of non-healed patients, all patients were treated by sucrose octasulfate. And what about outcomes? The results were really terrific because we had an healing rate of 48% in patients treated with sucrose octasulfate against 30% in patients treated by neutral dressing, but we find a 60% of chance, more of chance of healing in patients treated by sucrose octasulfate. But not only, in addition, considering the healed patient, we found that patients belonging to the study group had an healing time 6 days, reduced of 60 days in comparison to the control group. So more chance of healing, a reduced time of healing in comparison to the neutral dressing. Then, in the post-sub-analysis, in the post-hoc analysis, we found also that sucrose octasulfate was a more effectiveness than a neutral dressing, regardless of the ulcer duration at baseline. So we find that the study group reported 71% of healing against 41% of the control group in the case of ulcer duration less than 2 months. Then, in the case of ulcer duration between 2 and 5 months, we had 60% of healing against 38%. In the case of ulcer duration between 5 and 11 months, we had 29% of healing against 60%. In the case of ulcer duration more than 11 months, we had 22% of healing against 50%. So in conclusion, what about the lesson of Explore study? First of all, the Explore study showed that sucrose octasulfate is a useful and effective dressing for managing patients with neuroischemic diabetic foot ulceration, with an increase of chance of healing and reducing healing time in comparison to a neutral dressing. Not only, but the effectiveness of sucrose octasulfate was greater in comparison to the neutral dressing, regardless of the ulcer duration at baseline, even if early patient treated early with sucrose octasulfate reported better result than late treated patient. Finally, we can say that according to the robust evidence coming from the explorer study, the sucrose octasulfate should be considered the first-line treatment for patients with neuroischemic diabetic foot ulceration, and the treatment should be applied early to improve outcome, short and long-term outcomes. Thank you very much for your attention, and it's the moment of my colleague, Dr. Chris Manu.
Good morning, and thanks we've had a very good summary about what the ergostat can achieve in sort of controlled circumstances or in RCT. And then now it's just to look at the real life translation or the importance of early optimization of DFU treatment and how that can then generate cost savings. So next slide, please. So I think we can all agree that there are different healthcare systems across Europe. And although the RCT has shown that, yes, there's a benefit, it was good to have a look at the cost effectiveness in sort of in models. And over the next 3 or 4 slides, I'll just take you through 3 models. One is done in France, UK, and Germany. And also, so basically demonstrating that ergostat is a cost-effective compared to neutral dressings. And by comparing both, there's a clear economic dominance for the strategy of using ergostat. And even much more that the sooner, as we've all been hearing, that the treatment is initiated, the better are the outcomes in terms of the clinical benefits and perhaps the cost savings as well. And as we've heard from Raju as well, the quicker we close these wounds, the more that we can save or reduce amputations. So if you look at the figure on your right, I think what we really need to try and achieve is something that is cost saving, regardless of not looking at the cost per the product individually, but also the cost savings that can be achieved so that you move towards the top right corner where that it is less expensive and more effective. So looking at the cost effectiveness modeling done in France, this was done to mimic care over a 40-year period. And again, showing that comparing all the wounds, if all wounds were started on the ergostat, and again, if they were started earlier, i.e. less than 2 months, what the possible difference will have been. So from the first table on your left, that the possible life years that could be gained or life years gained with DFU on applying to the all wounds is 6 months. However, if this was applied earlier, then that can increase to 8 months. So just not looking at just the life source without DFU gained, but also the quality of life. And again, the quality of life of 1.9 months, but if started earlier can be as high as 2.8. But looking at the ICUR or the incremental cost utility ratio, again, from economical terms, is dominant in both cases in support of starting earlier, but of course benefits more the earlier it is started. And again, if wounds are closed earlier, per 100 patients, the amputations that could be saved is 3 for all wounds and 4 if it started earlier. So in essence, looking at again on the graph on the right side, for all patients, yes, there is a cost savings per year of using it, but from comparing it to starting it within two months or earlier, the cost savings is much better per patient per year that it can generate. So again, as I said, regardless of the health economics within the country, the ergostat in France treatment gives a better healing outcome and saves on treatment costs, reducing healing time, gain per year per life, and a good health for the patients. And the outcomes are better and the sooner it is started. And looking at the modeling that was done in Germany, this was done through the Markov model. and it was modeled to look at the treatment cost per 100-week period. And with this, the wound healing rate is more efficacious for all wounds, but here we're now comparing the old wounds with the neutral dressings. And it was more efficacious in the old wound states with the ergostat compared to neutral dressings. And again, if it started earlier, it was again even much more efficacious. So again, the same message was true in the German model, that the outcomes are better with ergostat the sooner it is started. And again, looking at the treatment cost for all the wounds with the graph on the right-hand side, with the red bars being the treatment with ergostat, for all groups, there is a savings of treatment cost savings of up to 30%. But when started earlier, this can go as high as a 43% savings compared to using neutral dressing. So again, the same message was true in the German model, that better healing rates and even better if started earlier, the treatment cost likewise the same as the France model, and economic-wise is dominant. Again, with regards to the UK modeling, this was done to model over a 1 year period. And again, same message was strong. This was rigorously checked by NICE as well. And the healed wounds per 1,000 patients, again, when used neutral dressings, 473, but with ergostats, much higher at 653. And the number of amputation events is lower in the ergostat group. And again, looking at the quality of life, with the ergostat, there was a better quality of life calculation compared to when neutral dressings were used. And again, the spending per patient per year, again, was significantly lower, with the graph on the right side, where the red bar is when ergostat is used, a savings of up to £435 per patient per year. So again, this was completely true for the UK model, that the ergostat treatment range gives better healing outcomes and savings on treatment costs, reducing the healing time, reduces dressing changes, nursing visits, hence patient's quality of life improving, and the economics is tense as well, again, a dominant strategy to adopt. So in summary, I think we have heard from the Explorer study in that, yes, ergostat reduces the healing time and healing more wounds, and that can be extrapolated to say, yes, it will reduce the number of amputation, improve patients' quality of life, and deliver more years of life without an ulcer. And again, as been, the evidence was strong enough for the NICE to say, or to recommend, the use of ergostat as the first choice of treatment for all leg ulcers and DFU. And not just for the healing of wounds earlier, but also on top of that, the healing, the three cost effectiveness models, as we've described in France, the UK and Germany, have demonstrated that it is cost-effective option compared to neutral dressings, and the sooner the treatment is initiated, the better the outcomes. But the key bit, as quoted by from NICE, is even if just 25% of people having treatment with DFU use ergostat instead of other non-interactive dressings, then the NHS may save up to 5.4 million per year. Thank you. I think I'll hand it over to Professor Làzaro Martinez now.
Thank you very much, Chris, and it's a real privilege joining with all of you in this webinar. Thank you, Hugo, for the invitation, for talking again about this interesting therapy, and a special message for everybody for joining with this meeting in this special condition. So I'm going to speak about all this evidence after 1 year of the inclusion of ergostat in some important guidelines and some recognition. So I think that everybody knows very well how or what is International Working Group Diabetic Food, and a special role launching every 4 years and important guidelines for recommendation for the prevention and management of diabetic foot diseases. So the last version of these guidelines was launched in the age in 2019. And in this new edition, it has been including the first time ever therapy associated with addressing, and especially with the use of the sucralfate dressing, in this case, Urgostar, for the treatment of the neuroischemic diabetic foot ulcer. Specifically, the guidelines say that consider the use of the sucralfate impregnated dressing in not-infected neuroischemic diabetic foot that are difficult to heal despite the better standard of care. So, without any doubt, this is an important milestone because this is included in the guidelines. This is a recognition of the strong evidence supporting the recommendation. But in my opinion, the more important thing is including another step when you are treating your patient according with the standard of care and specifically with the local care. It's not only important, or one important milestone was the inclusion of the Urgostar in the International Working Group Diabetic Food Guidelines, but another important milestone was the recognition by the NICE guidelines. The NICE guidelines published in the UK the recommendation for the different therapies among national health system in UK, and recommending to the use of the Urgostar for treating diabetic foot patients globally, not only neuroischemic, with the argument that this therapy can reduce the healing time, is easy to implement, can enhance the quality of life. And the more important thing, it's important, don't forget that we can save money, and especially important among European countries, the majority of us, we have and public national health system with a lot of cost, especially with this patient, and it has been demonstrated that we can earn, we can save almost 400 euros per patient when you are treating this patient with the Urgostar therapy. So in conclusion, in summary, we can say that there is two important milestones, including Urgostar, in this important recommendation guideline. And finally, with the publication of the guidelines, exploratory study has been included in the last meta-analysis that the International Working Group Diabetic Food Group of BOAR did, and it has been published in the recently paper in 2020, in which the use of the sucralfate impregnated dressing has been shown in the large well-conducted randomized encounter both along with peers. So that means that this has been recognized as, too in this systematic review and meta-analysis. And what more about Urgostar? So this is important to mention that at the beginning of the exploratory study, the rationale of using the Urgostar is mainly focusing in two modes of action. One of them is the control of the metalloproteases, or better say, the control of the level of the metalloproteases during the healing process. And the second one is the promoting the neoangiogenesis in the blood bed. So following with this rationale, we published recently, this is only 1 month ago, what is the mode of action of this dressing, of the Urgostar dressing, after the treatment of the patient, and what is the impact in the neoangiogenesis. So this is a pilot study that we published in the International Lower Extremity Wound Journal, with the objective to evaluate the improvement in the microcirculatory status in patients with neuroischemic diabetic foot ulcer through the use of TLC nose dressing. So the clinical result was concordant with the previous evidence. That means that this is an important wound size decreasing after 4 weeks of treatment. This is a significant wound bed improvement within the study, and the healing median time was very good. But the more important thing, in my opinion, was that we demonstrate the increasing of the TTPO2, that means the transcutaneous oxygen, in all the patients after the treatment with the Urgostar dressing. So we included 11 patients, and after the treatment, all the patients increased significantly the level of oxygenation at the local site after 8 weeks of treatment, and all of them at the bone closure. So that means that probably the Urgostar is working too in the neoangiogenesis and in the proliferation of the new vessels through the bone bed. And this could be the explanation of how is the mechanism of action, what is the benefit specifically in passing with impaired vascular status. Next slide, please. So back what happened after exploratory study? Because many people are talking about, okay, this is a randomizing control trial, this is an strong evidence, but the problem perhaps is how to translate all these results in the daily practice and how to implement in our protocol. So for this reason, it has been done, this new study in the real life with the objective to evaluate the use of new polyabsorbent TLC nose dressing in a large and selected cohort of patients with chronic wounds under real-life conditions all across Germany. That means that the use of this dressing is or was using according the indication of the professionals that are treating patients with different chronic wounds with different etiologies with a duration of 12 weeks and among 130 centers. So in this study, 1,140 patients have been included, and they analyze what is the outcome with the use of these two new polyabsorbent fibers dressing, additionally with the TLC nose technology. So what about the inclusion of the patient? So you can see here in this slide that the several chronic wounds have been including venous ulcer, pressure ulcer, other wounds, other etiologies, and diabetic foot ulcer. Diabetic foot ulcer included was approximately 25% of all the patients, and this you can see in the right of the slide what is the percentage of the different dressing that has been used during the study. So one important thing is what happened in the real life, and this is the figure, the paramount that you can show. You can see when you are treating patients. That means that the bone duration, the healing state, the level of the exudate, and even the size of the ulcer are very heterogeneous according with the result for the patient included in this study. So you can see here, for instance, so half of the patients have a bone duration more than 1 month. The majority of the patients have a sloughy tissue at the foot bend. The level of the exudate is moderate or important in more than half of the patients, and the median wound area in the diabetic foot ulcer is more than 3 centimeters square. You can see here what is the outcome concerning the wound healing and the healing rate and trajectory. If you are seeking for the bar for diabetic foot ulcer, you can see how approximately half of 50% of the patients healed during the study. At the final visit, the wound closure or an improvement in the wound healing was supporting in 93% of the treated wounds. Another important point is what is the response of the patient treated with this technology. So you can see, for instance, that 94% of patients treated for diabetic with ulcer have an important relative wound area reduction in different visits. That means that all patients respond well, or almost all the patients respond well after the treatment of this technology. And this is a very important information concerning what is the state of the ulcer when you are including in the study. And this is sometimes some of the questions that the people are wondering when are challenging the result for exploratory study concerning what is the state of the ulcer. If the ulcer has been debrided, if the ulcer has in the granulation state, if the ulcer suffered for or has a sloughy tissue, fibrin tissue, and concerning the duration. So the result of this study demonstrate that probably in the current situation of your patient, in the daily practice, in the majority of the status in what you can find the patient, the technology responds very well too, because orgo-start dressing are efficient on the wound healing process, regardless of the wound healing stage, and of course, is concordant with the previous studies, is better the response if you using the better the better sorter. So in conclusion, we can say that the result of this observational study demonstrate or corroborate the findings of the previous clinical trials for TLC nose, confirm the clinical interest of this new technology, and again, important message, the sooner the better. So you don't have to wait to use this technology if you are right or you are sure for the indication. This is an important message, and active effectively and the sloughing and granulation stage until conclusion in all chronic fluid. So again, this is an effective, safe, and simple treatment for the local management of chronic. So we were discussing about technologies, we were discussing about evidence, we were discussing about treatment, recommendation for the management of the local care of diabetic foot ulcer, but one of the important problems that we still have is the lack of awareness. The lack of awareness not only in the healthcare provider, not only in not specialties, is to the lack of awareness in our patients. For this reason, in collaboration with DFU International, Urgo Foundation has launched this awareness campaign with 3 objectives. The first objective is the early identification of vascular risk. The second is the appropriate referral of patients presenting complicated diabetic foot ulcer to a multidisciplinary team. And the third one, the education of patients and non-specialist healthcare professionals on diabetic foot ulcer. So the awareness campaign is based in different materials you can find in this website, www.safepeacelike.com, in which you can find different materials such as posters, educational videos, social media and professional content, newsletter. And the more important thing is that you can join and you can spread through your patient and through your colleagues for increasing the awareness concerning diabetic foot ulcer from the beginning. So about what is diabetic foot ulcer to the end, in order to reduce the late referral and treating to improve the diabetic foot care of our patients. So in conclusion, we can say that diabetic foot ulcer represents a high burden. The local treatment is an integral part of diabetic foot standard of care. Remember, this is very important when you are treating the patient. Don't forget the standard of care. The Urgo-Stat has shown a superior efficacy on reduction of Kelly time and cost effectiveness comparing to neutral dressing, confirming through real life data. So the use of Urgo-Stat in the first intention for your patient to fully benefit from its added value. So the international guidelines recommend Urgo-Stat for treatment diabetic foot ulcer. This is an important milestone. The new evidence could contribute to understand the mechanism of action, especially the effect in the local improvement of the angiogenesis. And on top of implementing the better standard of care, prevention remains the key to reduce diabetic foot ulcer and amputation at death. So remember to join the SafeFit Life community. Thank you very much for your attention.
So I like to thank to all speakers for their excellent presentation, and the papers are now open for discussion.